hemoglobin A when that reversed at the initiation of insulin therapy. This is a much smaller, trial, but shows the same thing. So that was great. Insulin can actually help with the pulmonary function. What about pills? Can we give pills to these patients? They don't really get all excited to take insulin shots. So here's a study where they actually looked at repaglinide, which is a pill that can cause your pancreas to make more insulin. So here we can see patients, this is the insulin level in the blood in patients who are controls. So these are patients who, I think these guys had a mixed meal. So they had a meal and the insulin goes up in the controls and then it goes down. And again, these are all the patients at baseline, these squares. There's a patient with CF diabetes at baseline who didn't take anything. Again, a delayed and diminished insulin response. That's why they're diabetic. And then if they took insulin Lispro, this is their insulin response. And if they took repaglinide, the pill, here's their insulin response. So these don't look that different. Let's see what their blood sugars did. So here is the control, not elevated glucose. Here is the patient that took the insulin, the Lispro, and here is the patient that took nothing. This is the baseline, so they're high, and here's the repaglinide. So the insulin is clearly lowering the blood sugar better than the repaglinide. That's just one study. And then they did a randomized controlled trial. This was the first randomized controlled trial in CF-related diabetes without fasting hyperglycemia. So they were really focused on this group who didn't have blatant fasting hyperglycemia. Should we be treating these guys? So this study is a little bit disappointing in that it didn't show more dramatic results, but it did show a couple of things. So there were 81 adults with CF without fasting hyperglycemia who were either diabetic, with the 2-hour sugar being 200 or greater, or they were almost diabetic. They call it severe impaired glucose tolerance, severe IGT, where the 2-hour was just under 200, but at 1 hour they got over 200. And they were randomized to pre-meal insulin with aspart, where they did, this is called a carb ratio, so it's 1 unit for every 30 grams of carbohydrate. That allows flexible dosing according to how much carbohydrate you eat. Or repaglinide, the pills, 2 milligrams every meal. Can you see how different this is? This is totally flexible dosing. If you eat a big pancake breakfast, you take a lot of insulin. Here, you're taking the same dose every meal. And I think that's why that study didn't show anything, because you're just taking a fixed dose. So, of course, you might not control the blood sugar as well. If you could, with repaglinide, you can actually dose flexibly. You could take multiple pills if you wanted, based on the size of your meal. But it's hard, they didn't do the study that way. They did, in all of these cases, if they were really out of control on the repaglinide, they had a certain cutoff blood sugar, they would increase the dose. But it's still not flexible, with the patient controlling it like the insulin. And then they compared them to placebo. So the endpoints were at 1 year, the body mass index, the FEV1, DEXA scan for bone density, and NIH prognostic score, and some other things that I'm not really going to even talk about because they didn't show anything. So let me show you what it did show. So the group that got assigned to the insulin had an increase in BMI. This is a p-value, a significant increase in BMI of about 0.4 kilos at 1 year, compared to the repaglinide, who did not have it was a non-significant increase in body mass index, and placebo didn't change. The FVC and the FEV1, you can see these are all the p-values here. A p-value under 0.05 is considered statistically significant. So you can see that, this went down a little bit on insulin, this went down a little more, this went down, down, down a little more. But none of these were statistically significant compared to the baseline. So it wasn't thought that any intervention affected anything to do with pulmonary function. It takes a long time to see changes in pulmonary function, at least a year. And these guys, remember, they weren't that hyperglycemic. And in fact, when they looked at the hemoglobin A1Cs of these guys, there was no significant change. So sometimes studies that are negative because there wasn't enough difference between the groups, or because they didn't have enough pretest probability of having an event. There are various reasons. But there was this significant finding, so that the insulin was helpful for BMI. So they call it a nutritional benefit in patients without fasting hyperglycemia. And this is actually part of why the recommendations changed to lump all these CF diabetes together and recommended insulin treatment for them. Do you know what I'm saying? I'm going back to that position statement. Okay, here's the other thing that was found that leads these organizations to say, no, you can't use pills, you need to use insulin. The repaglinide, not only did it not show any benefit, but the repaglinide compared to placebo had a significantly worse effect on BMI in the patients who were almost diabetic, the severe impaired glucose tolerance patients. So this is the only significant thing in the BMI here. So the repaglinide fared worse than the placebo. Okay, so the organizations endorse insulin only because only insulin's been shown to improve the pulmonary function or the nutritional status. That being said, and I agree with insulin and I promote insulin, however, I will use pills as a bridge to insulin in many patients, and in patients who have a hardship with insulin, I will use some pills. And there are patients who do have trouble with insulin. I mean, insulin can cause hypoglycemia. And if you want to take insulin safely, you really can't take a fixed dose. You have to do flexible dosing, which means you have to count carbs. And that can be hard for patients. There are some patients who cannot do it, and they tried and they end up having severe hypoglycemia because they can't get it right, or they don't eat when they thought they were going to eat after they dosed. And for those patients, I will try to do a pill, or I'll do a pill with a little bit of background long-acting insulin. So there are pills out there that can be used, and I do agree these studies were negative, but I also agree, I also believe that the studies were somewhat imperfect when looking at the pills. Theoretically, if you could lower the glucose just as much with a pill, so in someone who had very mild early diabetes, then they should get the same benefit. But we don't see that, and the pills really are limited. I don't think, as the diabetes advances, that any of the pills would really do the job. We do have sulfonylureas. There's a risk of hypoglycemia. I do not really use these drugs very much. They're very long-acting. I'm just too worried they're going to get hypoglycemia. Repaglinide and Starlix are much more expensive than the sulfonylureas. I actually do use these drugs sometimes. That is not any standard of care. That's just me, because they're shorter acting and they're easier to titrate. So you can do a low dose and a high dose of this one if you're having a small meal or a big meal. This one you can take 1 to 4 pills depending on how big your meal is or how much carb is in your meal. But these again are really a bridge to insulin. So when someone is first diagnosed and they're starting to think about the diabetes, but they don't want to be checking their blood sugar and carb counting and taking shots all the time, we'll use these for a little while. Byetta is a drug that I've seen being used mostly in patients who are coming up from San Diego, which is where Amylin Pharmaceuticals is. I do not think this is a good drug for patients with CF because it causes weight loss and a lot of GI side effects, and it slows gastric emptying. It's like the worst drug I can think of. I mean, they already have slow, gastric emptying and problems related to their bowels and weight loss. So I wouldn't really want to use that drug. Januvia is another drug that it doesn't cause hypoglycemia. It actually acts on the same pathway as the Byetta. It causes your body to make more insulin in response to a glucose elevation. And so both of these drugs cause a post-meal spike in insulin in proportion to the degree of glucose that the pancreas is seeing, or the gut is seeing actually. So this is kind of an interesting drug. This is not approved for use. I think that in the patient who cannot take insulin, it's an option. It's a best option in someone with mild enough CF-related diabetes, because so what I've done is in patients who really can't do this carb counting and the multiple doses a day, I put them on a little bit of long-acting insulin and Januvia, which targets or minimizes the post-meal spikes. Diet is important. As I mentioned, patients need to eat to maintain or gain weight following the standard CF dietary recommendations. We don't do an 1,800 calorie diet. We don't do an ADA diet. We don't tell them to stop eating Skittles, although sometimes I'm tempted. Scandi shakes are very glucose elevating. A lot of the foods that the patients eat, they eat whatever they want because they're always trying to gain weight, but there are a lot of simple sugars and carbs that probably are not the best for their diabetes, but at the current time, and I stand by this, the recommendation is to just do whatever the CF team and nutritionist is recommending. In order to optimize diet for blood sugars, we can do a couple of things. One is make sure that the meals are mixed. That means protein, fat, and carb in the same meal as opposed to a pure carb meal. Fat is good for another reason, which is that it slows the absorption of the glucose. So that early spike in glucose that the CF patients get, it doesn't happen so dramatically. It's a slower rise and then a slower fall on the glucose. So adding fat is a great way to add calories and gain weight. And so instead of withholding anything to lower the blood sugars, instead I'll say, well, add fat to that meal because you're getting high after breakfast every day. Another thing that patients can do, patients with CF, as you know, eat a lot of small meals. They snack, graze all day long, and that can be really hard when you have to shoot insulin every single time. There are insulin pumps. I wasn't going to get into that here. But for patients who aren't interested in a pump, what you can do is for some of the snacks, you can have a snack that does not require a shot. So these are carb-free snacks. They can have protein and fat, but foods such as cheese, peanut butter, nuts, avocado, meat, and eggs do not require a shot. So they can have a snack, they can get their calories, but they don't have to take a shot with that snack. So, they could eat breakfast, lunch, and dinner, and maybe the mid-morning snack would have carbs and get an extra shot, but maybe the afternoon snack would be a non-carb, non-shot snack. And that's also something to do at bedtime if you're getting these really high blood sugars in the morning, is to have a no-carb snack. And then I think I already made this point that we don't cut carbohydrates to avoid high blood sugars. Instead, we add fat to the meals and try to have mixed meals. I just want to mention exercise in here. CF patients, just like any other diabetic patients, can get hypoglycemic from exercise. So if there is planned activity, whatever dose of insulin is being given, or even if it's a pill, should be reduced. It can either be held or it can be reduced by about half, because for the same meal and the same dose, they will get hypoglycemic. All right, so insulin, moving on to insulin, is the only approved therapy in the 2010 position statement. I will start the patients very quickly if I get somebody in the hospital or they come to clinic, get them with the educator, and we start carb counting right away, unless they're resistant, in which case I'll do the pill bridge to insulin thing. So we'll start with a carb count. A typical starting place is maybe 1 unit of insulin for every 30 or maybe 60 grams of carbohydrate. So different meals will have different amount of carbohydrate, and then they have different units. But it's really great. It's very flexible dosing, and patients can eat whatever they want. I will add Lantus, which is a long-acting insulin, only if the blood sugar is high in the morning in the absence of uncovered food at night. I can't tell you how many patients I have. They come to me on a lot of Lantus, and eventually they'll be hospitalized and they'll be NPO for something or another, and their insulin requirement will become 0. So all that long-acting insulin they were on was covering grazing, and it's okay to do it, except it can be dangerous if they stop eating. So I try to be pure with my insulin dosing and have the long-acting insulin truly be their requirement for overnight and in the absence of food. And all the food is being treated with this rapid-acting bolus insulin. But sometimes for patients who really graze a lot throughout the day, it's okay to have a little bit of this, not all of it, but a little bit of the long-acting insulin on board, as long as you realize if that patient gets admitted and they're NPO for bowel obstruction, you're going to need to cut back. At home, I tell my patients, and this is not a guideline that I found anywhere, to check their 1-hour post-meal glucose. You probably didn't notice, but if you look back at the figures, the peak glucose in CF patients is the 1-hour post-meal or the 1-hour post-glucose drink. And since we're always trying to stay under 180, I tell them to check the 1-hour post, and our goal is to keep it under 180. If they're always over 180 or on average over 180, then we might need to adjust the therapy. So that's usually their carb ratio. So if they're taking 1 unit for every 30 grams, maybe they need 1 unit for every 20 grams of carbohydrate. We do monitor the A1C. The position statement or the standard goal for patients with CF is under 7. I'm not sure what that's based on exactly, but that's always a moving target for all diabetics. But right now it's under 7. And then we can add a sliding scale, which is a insulin given for high blood sugars. But compared to other diabetes, we really don't rely on this very much. The mainstay of the treatment is this carb counting. So patients with CF diabetes need a lot of insulin for carbs, but they do not need a lot of insulin to bring down a high blood sugar. I put down here a ratio of 100. What this means is 1 unit will drop their sugar 100 points in the absence of food. I mean, they're very, very huge drops from 1 unit of insulin in the absence of food. So we have to be very careful about using that. Okay, so as I explain it to the residents who are training with me, that their patients with CF-related diabetes are very carb intolerant, but they're very insulin sensitive. So the mainstay of insulin is for the food that they're eating, as opposed to reacting to a high blood sugar and giving units to bring it down. And I think it's easy for the patients to remember a single number. So 1 hour post, we always want to keep it under 180. So then here's the official, this is the last slide, the 2010 position statement on treatment. So only insulin is endorsed. It is recommended that they self-monitor their blood sugar over 3 or more times a day to be safe if they're taking multiple doses of insulin. The diabetes education should meet national standards for all diabetics. They should be seen quarterly by a specialized multidisciplinary team that includes somebody who can treat diabetes. The A1C should be done every 3 months. The goal is under 7. They should get exercise. They should get hypoglycemia education and have a glucagon emergency kit, which is a treatment that can bring up your sugar if it's very low and you can't drink juice. They should get annual monitoring for microvascular complications, so that means eye exams, monitoring the kidney function with a urine test, and these should start about 5 years after diagnosis. And if they are found to have these kind of complications, they should be treated the same as any other kind of diabetic. And then they do recommend an annual lipid profile. That's checking the cholesterol. As I mentioned, they don't usually have high cholesterol, and they haven't had any reported cases of heart disease. So this is only really necessary if they have a risk factor. So if they're obese, or they have a family history of heart disease, or if they have been transplanted. Once you get transplanted, they start to have high cholesterols from the drugs. So it's nice that there are actual guidelines out there, because there weren't. And I think they'll continue to progress as we hopefully get more data on outcomes and responses to different interventions. So in summary, glucose intolerance diabetes is common in patients with CF. Remember, 70% have some kind of abnormality. And it starts with normal fasting, but high post-meal glucose excursions. Mortality is increased 3 to 6-fold in CF patients who do have diabetes. And the pulmonary decline starts even before fasting hyperglycemia develops. Treatment with insulin slows the pulmonary decline by up to 34 months and improves the body mass index. Oral agents, pills, have not been proven to do the same, so insulin's the ideal therapy. And subjects with CF are very carbohydrate intolerant, but relatively insulin sensitive. And they require carb-dosed mealtime insulin to allow them to eat freely and flexibly, to maintain their body weight, and to avoid the risk of hypoglycemia. All right, well, thank you.